Good evening, Julian.
Good evening, Mike. And how are you?
I'm excellent, thank you, and welcome everybody to Series 2, Episode 4 of Veterinary Ramblings. My name is Mike Brampton.
And my name is Julian Hode.
Do you know, I didn't quite recognise you there.
No, I was in disguise.
All right, had you got a mask on?
Yeah, you couldn't see it. They're invisible in daily usage.
Oh, right, excellent. Yeah, you sort of take it for granted that people are going to wear masks these days.
I don't notice them anymore.
No,
Yeah.
I don't either. No, absolutely. Hi, I'm Mike Brampton.
And my name is Julian Hode.
Welcome to Veterinary Ramblings. But before we go on, and before we start introducing tonight's guest, I think we should make it perfectly clear to everybody that if you're the sort of person that complains about the table next to you in a restaurant, talking about wounds or blood or gore or infections, because it's putting you off your tea, you'd better switch off now.
There's going to be lots of gore tonight. Lots.
Because this is Veterinary Ramblings, and this is where who knows where the conversation will go or what we're going to talk about. And we wouldn't wish to
go anywhere.
We don't want to offend anybody. That's not our intention. Our intention is to educate, amuse, and generally have some fun. And if you're involved in veterinary or veterinary medical or medical fields, then very often that's how we unwind. That's how we get some of the stuff that we deal with on a routine basis out of our system so that we can pitch up the next day and go through it all again.
So if you don't like jokes about pus making guacamole, then don't listen to that one.
No, don't listen to that one because that would be awful. So, should we start the show, guy?
Let's start the show. And we've got another very special guest tonight, haven't we?
We have indeed. A very special guest. He uses lots of long words that I struggle with. So perhaps you'd be kind enough to tell the audience, Julian, about our guest, and then we'll announce him and get him in out of the way, because he's actually in the waiting room now.
He's in the waiting room. He's waiting for us. He's poured himself a gin. So tonight we have Mr. Nick Saunders. Now, Mr. of course means that he's a surgeon. He's a human surgeon at that. Not just a human surgeon. He's one of the leading ENT surgeons in this country. He's an examiner for the Joint College of Surgeries, the Intercollegiate College. He's also an examiner for the European Board of ENT Surgery. And he specialises in middle ear and skull-based surgery. His name is Nick Saunders. He's in the waiting room. Let's get him in now.
Hey! So, Nick Saunders. Hi.
Hi, Nick.
Good evening.
How the devil are you?
I'm very well, thanks, Mike. How are you?
I'm excellent. Thank you very much indeed. We've told the audience that if things get a bit gruesome, they should just switch off. They shouldn't be watching us in the first place.
Yeah, they shouldn't listen to discussion about pus and discharge and smelly things, and blood pouring out everywhere, and brains oozing out of the sides of skulls. So we won't mention those at all.
No, I wouldn't. Not for the squeamish, for sure.
I wouldn't.
Absolutely.
Have you got a drink?
I have. I'm on the Brockmans tonight with fever-tree elderflower, which I have to say is a rather good combination.
I haven't tried the elderflower one. I've got a bottle of lavender dry gin, with fever-tree as well, and it's jolly nice. It's got a sort of pale pink colour, the purple.
Cheers.
Have you had any barbecues recently, Nick?
I have with my green egg.
Yeah. So
other barbecues are available.
They are, and they're different. Egg. Yeah, Nick's got a green egg.
I've heard of green tomatoes, but green eggs.
It's brilliant. It's a Komodo style oven. Other large monitor lizard-based barbecues are available.
It's one thing. My culinary skills aren't quite up to the level of Julian's, but it covers a multitude of sins, and it can make most things taste pretty decent.
Sure. Well,
it uses about that much charcoal.
Mm.
Is that because you've got a small green egg and he's got a Mongolian fire pit to feed the Mongolian hordes as they ride across the steppes to invade China. I've seen. Have you seen his?
Yeah.
Have you seen his
I
fire?
have seen his barbecue. It is fantastic. It is fantastic. You do expect to see a yak roasting on it, to be fair.
You do. And you could probably get a yak.
I've got one on order. Hasn't arrived yet.
What, a yak?
Yeah.
If you bought it as a whole or as a half?
Just a half-sided yak.
Half side, yeah. Okay.
Not a tapir.
No. We can't afford such delicious meats. You have been watching, haven't you, Nick?
Hey, I managed to cook Yorkshire pudding on my barbecue last weekend.
Right. What, with the yak?
How dare you talk about my wife like that? No, she sat and watched. I'm going to get it in the neck for that.
Yeah, but Julian. Before we go too much further, I think we'd better be very careful because it appears that this guest has actually seen previous episodes.
Bugger. That's never happened before.
I'm going back incognito, I think.
Let's go back on this. Look, I got not enough praise, I think, for my cooking Yorkshire puddings on a barbecue.
Oh right, you did what, Julian? You cooked Yorkshire puddings on a barbecue?
Yorkshire pudding, got the Dutch oven on top, put it up to charcoal mark 5, and got the temperature nice and hot. Put the oil in, put the Yorkshire in, slightly burnt, but yeah, it's all right.
That's amazing. I can't keep.
Wow.
Are you a charcoal man, Mike, or are you?
Me, I'm a wood-fired barbecue man.
Yeah. See, mine's dual fuel.
Oh right.
Yeah.
What, wood and charcoal?
Wood and charcoal. Mm.
Yeah.
So wood and older wood.
Mm.
Yeah. Let's face it, we're all wrecking the planet with our barbecues, but
Other ways of wrecking the planet are available.
Yes.
And
Driving to Barnard Castle.
Yes, unnecessarily.
Yeah.
Yeah, that's probably about the only one, actually, isn't it? Because he's wrecked lockdown and the environment. Yeah.
But it's okay.
I said I wouldn't talk about Dominic Cummings tonight.
Yeah.
So I won't.
It gets a little bit.
So when you're not on your barbecue, Nick, you are cutting bits of skull out of people's heads.
Cutting, drilling, very occasionally chiseling. Yeah. All other methods of removing bone are available.
Yes, I've seen them. I was at a Millwall football match once.
I do quite a lot of that. Just sort of moving various bits of bone and putting new bits of bone in different places and moving stuff around and
Now, one of the things that you constantly amaze me actually with the things you do, because I do obviously surgery on dogs and cats. You make my surgery look more like I've got a chainsaw, because you do very, very precise surgery, and you actually replace the ossicles of the ear, don't you?
Yeah, I do. The fiddliest operation, I think probably the fiddliest operation that anyone does, actually, and probably in the whole of surgery, is called a stapedectomy. And I don't know if many animals have stapes. Most of them are single ossicles and columellars, aren't they? But the human ear's got the 3 ossicles, and sometimes the stapes gets fixed. It should move in and out like a piston in a cylinder. Mm-hmm. And if you extend the car analogy, essentially the piston rings get coked up and the stapes stops moving. And that gives you hearing loss, and you can use a hearing aid, or you can try and bypass it with some surgery. And the surgery is, it's quite fiddly. You basically take off the top bit of the stapes. It looks like a stirrup, hence the name. And you take off the legs and laser a little hole in the foot plate, the bottom bit, and then hang a new piston, a new hang a prosthesis in. To give you some idea, the diameter of the hole you laser is 0.8 of a millimeter. The diameter of the piston is 0.6 of a millimeter. It's 4.5 millimeters long with a little coat hanger on the top that you've got to hang over the incus and then laser in place. So it's not one to do after a big night out.
And you don't have too many coffees that morning, do you?
Actually, I'm quite unusual in that coffee doesn't give me a tremor, so I'm quite lucky on that one. But no, you wouldn't want to be doing it if your hand was a bit shaky, for sure.
So you're not doing one tomorrow morning then?
No, I'm not. You'd be pleased to hear I'm not.
And how long would you say it takes you to do that sort of surgery?
That's a couple of hours, which is actually quite quick compared to a lot of the stuff I do. Some of it will take 3 or 4 hours. If you get a big middle ear cholesteatoma or something, that'll be 3 or 4 hours of guzzling around in something about the size of your thumbnail.
Yeah, wow. That's a lot of guzzling around, isn't it? The big problems, I guess, are going to be avoiding the delicate structure, the facial nerve, the venous plexuses.
Yeah. I mean, there's a lot of clockwork you don't want to mess up in quite a small area, and it's all in 3 dimensions. And you've got to kind of know where you're going, and you've got to know it fairly intuitively. I teach on quite a lot of anatomy courses, and I run a couple. And
are you operating down a microscope then, Nick?
Oh yeah, binocular operating microscope.
Right. Okay.
But
begs the question: how do you learn to do that, or how do you accurately teach to do that?
A lot of books, and then cadaveric dissection. There are all sorts of clever 3D haptic simulators, which are not great. Some of them are okay, but then they're fine for absolute raw beginners. But for once you get past that stage, there's no real substitute for simulation. And there's plastic temporal bones you can use, and those are quite good. But actually, there's no real substitute for cadaveric dissection, and the courses I run are based on that. Because you've got to know your anatomy intuitively. The spiel I give to the candidates is because all the anatomy is usually deranged, and you're in there. There may only be 1 or 2 landmarks, and all the rest may have been destroyed. You've got to know it in the same way that if you've grown up in a village all your life, and you get dropped off at 3 a.m. after too many pints in the fog, you know how to get home from one lamppost.
This sounds very much like a trip back from the riser on one Christmas.
Was that the time you fell in the pond, in the village pond?
It was very icy. It was, to be fair to Julian, it was very icy.
Yeah, we almost ended up in a little stream. It was about that time that we used our friend Jonathan as a toboggan, wasn't it? A few of us sat in him and scooted along.
Yeah, I don't think he enjoyed that much, to be fair.
Never forgiven us, no.
No.
So, can you, when you have students learning how to do this, do you ever record what they do and talk them through it afterwards?
Yeah, we've started doing that. We've done quite a lot of stuff.
I read your paper earlier that you'd written about that.
Oh, well done. I'm impressed. Done your research. Yeah, no, you can. You can record it. You can send it back. You can go back and critique it. You try and do that individually rather than in front of everyone else, because teaching by humiliation is apparently passé these days.
Do you give a feedback sandwich?
I tend to use a baguette.
Nick?
I was talking about baguettes, I think. Sorry, I was just Parma ham and nice cheese. I was miles away. Sorry.
There we go. Feedback sandwiches.
Feedback sandwich. Well, the point that I was making was this other instructor didn't quite get it, you see. So we had to give a feedback sandwich. He did something good, did something bad, did something good. So he looked at his fellow climber. He said, that was crap. And the instructor said, no. Remember, his feedback sandwich is something good, then something that needs a bit of a tweak, and then something good, something positive at the end. He said, okay, I like your harness. It's new, is it? Anyway, you're climbing shit. Your bum looks good in the harness.
So it tells me that Nick is far more subtle than that, Julian.
Oh, I don't know. Are you, Nick?
Yes, for the purposes of this podcast, I am a model tutor.
Good. I thought so. I thought so.
I got to pull
So
myself.
you wouldn't ever say to an intern, please feel free to cope if you need help.
I would occasionally use, obviously purely in jest, as a supportive trainer. I would only use that to someone who I felt was ready to cope with that level of banter, shall we say.
So now I managed to bring the conversation round to climbing, but actually, Mike, you rather neatly brought it round to cycling, didn't you?
Yeah.
Nick, do you?
Yeah.
Nick, can you stay with the program here?
I was still on cheese and ham baguette. Sorry.
Have you eaten tonight, Nick?
Yes, I have. Sorry.
You have, but you didn't get a cheese and ham baguette, did you?
I didn't get a cheese and ham baguette. No.
That's your ultimate favourite dish, isn't it? Cheese and ham baguettes.
Yeah.
Well, I tell you what, if you pay attention, we'll get you a cheese and ham baguette.
I've had some really good cheese and ham baguette cycling.
Have you really?
Yes.
Okay.
In all sorts of nice places.
So you utilise the carbohydrate means of fueling.
You know, I mix carb and protein. Obviously, a little bit of protein from the ham and cheese.
Mm-hmm.
So yes, and it's doesn't get sweaty in your back pocket.
I think I just missed the baguette out of the butter and the cheese and a little bit of ham wrapped around it.
Sorry, can I just say to viewers, never carry around a chicken and ham baguette in your back pocket. It probably goes against several hygiene rules. And it just looks wrong. Certainly don't put it in your front pocket. That looks even worse.
I tell you, as more and more people are out on the roads and more drivers are actually giving cyclists some space on the roads nowadays, the best thing I found for this happened quite by accident was that early one morning I came across a pheasant that had been freshly killed on the road, and I thought that's not going to waste. So I tucked said pheasant down the back of my jersey, and I had a predominantly white jersey on at the time, so that was interesting. And the tail feathers were sticking out at the back, and so it sort of looked as if I'd been shot in the back, with the blood seeping through the white jersey and obviously dripping down, or some of my entrails were hanging out the side. I had no problem with cars giving me a wide berth that morning whilst I'd got the dead pheasant in my back. But I wouldn't recommend that either. So you ride bicycles?
Highway code?
Sorry?
Is that in the highway code that you should use a dead pheasant to avoid cars passing you too close? Because it should be. It should be if it isn't.
Well, yeah.
I think it is. Mike's essentially carb free, aren't you? You're still carb free, Mike?
No, not really. Not really. As you can see, I drink Fever Tree tonic, and this evening, as we've discussed, I'm drinking this. But yeah,
Lone Wolf McCade. You were essentially carb free for quite a while, though, weren't you?
Yeah, particularly when I was racing bicycles. So that was no bread, no pasta, no rice, no potatoes. Essentially, yeah, carb free.
That's moderately controversial for a racing cyclist.
You've come across the big controversy at the moment of cyclists taking ketones.
I'm going to just drink gin for a while, by the way. You carry on, guys.
Yeah, you carry on and drink gin. I don't know. The pros will all spend a couple of months in the winter doing low-level fat-burning training, and they are essentially carb-free during that point. Julian's getting a double shot of carbs there. Okay, Julian, we'll drop off the screen.
Are we boring you, dear?
No, it's exciting stuff. So this is the keto diet, isn't it?
Yeah, it's the ketone diet. But what's the big controversy recently is that is it Oxford University have produced a readily assimilable form of ketones that people can drink to fuel their activities? And
no, someone drank some nail polish remover by mistake.
Yeah, something like that.
They wrote it up.
No, it's quite a big controversy because it's not banned as a performance-enhancing substance, and why would it be?
But then neither's tramadol.
Have you been doing your research?
You don't know that, Julian. You're allowed tramadol in the last bottle. So, say in your last bottle before the sprint, a lot of racing cyclists will have tramadol. That was blamed for quite a lot of crashes at the end of big races because they reckon that they were just a little bit slowed down on tramadol.
Really? It wouldn't work for me because I projectile vomit after eating tramadol.
Well, there you go. So,
mind you, if there's someone ahead of me on the bike, they'd stop and just have to clean their jersey, wouldn't they? So
no,
if you can turn your head while projectile vomiting, then that will give you some form of propulsion.
Yeah.
I don't know if I've got the time or control when I've got tramadol on board to do that.
And may also upset the people trying to overtake you.
Yeah, but that's a big advantage, isn't it?
Mm. So. Okay, I'll try it.
Yeah, no, don't.
Fancy the bike ride, Nick?
God, I don't know. I want to get into a bit more into the surgery you're doing there, Nick, because well, some of the stuff I saw was you're talking about surfer's ear.
Oh yeah, now that's an interesting one. The ear canal is the only place in the body where skin sits directly on bone, right. And there seems to be an odd reaction when you get immersed in cold water that makes you make more bone. And if you surf, windsurf, open water swim in cold water, you get these little bony growths in the ear canal that can almost completely close off your ear canal. And some people have done some quite fun research to look at why and how it happens. It's very much down to repeated immersion. So if you're in the water for a long time, you don't get them. Divers don't tend to get them. And it seems to be down to cooling. So if you look at the surfers on the west coast of the States, as we know, surfers spend most of the time sitting on their board looking out to sea, waiting for the next wave. Yeah. And in the States, there's a prevailing northerly wind in the winter. And if you look at the surfers out there, they have twice as many extrastases in their right ear as they do in their left ear. And it's the cold wind blowing in their right ear that gives them bad extrastases in their right ear.
So if these guys really got into it and actually put earphones in to listen to the Bee Gees or the latest West Coast surfer sound, then they probably wouldn't suffer from problems.
Probably not. It might ruin the earphones, but they would probably. No, they do actually wear earplugs now, and the recommendation is to wear earplugs. And in fact, there's some quite funky little ones. They've got a little Gore-Tex membrane down the middle, so you can still hear the wave coming. You can still hear people shouting, "Get off my wave!"
I've seen those. And they work. They help.
They work really well.
All right.
They work really well.
So I figure in that case, then I'm going to share my screen with you. You wouldn't recommend this then?
Oh no.
For those at home that can't actually see this, I'm showing a picture of a surfer captured a couple of years ago in the Arctic Circle, and he is catching a wave and surfing aggressively under the moonlight, but also lit by the aurora borealis, the northern lights, shining down on a snow-capped peak. So you wouldn't recommend that then?
Well, he'd probably be all right because it's probably so cold. He'd only been there for about 5 minutes, so he'd probably get away with it because it's actually down to sort of repeated immersion and duration. So he'd probably be all right.
Oh, okay.
And actually, interestingly, one of the things they say is that the reason people get them now is because of wetsuits. Because in the old days, you couldn't stay in the water very long, so you didn't get extrastases. But now you can stay in the water longer.
Right.
You get extrastases because you've got decent wetsuits. But they've used them for all sorts. They've used them for anthropology. Because it's not just surfers that get them. And if you look at skulls from burials, you can work out what people did and how they got their food. Because, in 3,000 years BC, if you wanted to get fish, you had to go in the water and get your fish. You didn't have a boat or a net or a carbon fishing rod. So you can tell what was happening in communities and whether they were fishing. And you can even look at sociology with it. If you look at some Roman burials from different parts of Italy, you can work out the social structure, because if you see that was obviously a rich burial, in some towns, in the rich burials, the skulls don't have exostases, and in the poorer burials they do, implying it's a fairly hierarchical structure, and the richer people did what you expect rich Romans to do, and sit around feeding each other grapes.
And orgies.
And orgies, obviously,
Yeah.
and orgies. Yeah. Whereas in some of the burials, even the rich burials have got exostases, so even the rich people went fishing, and it was thought to be a flatter, less hierarchical structure. So you can even use it for sort of anthropological sociology, which is about the only thing in ENT that you can, to be fair.
And there was a theory, wasn't there? That actually it may be due as well to people using the frigidariums, that these 3 rooms of the baths, the caldarium, the tepidarium, the frigidarium, and so a lot of the Romans that were found to have these exostotic growths probably spent a lot of time in the tepidarium and frigidarium rather than necessarily than the caldarium. And there was a feeling, is it more expensive to use all 3? Were they the ones who just used those ones because they preferred it, or because they could only afford the colder ones?
I have to say, every day is a school day, because I didn't know that. So you got me on that one. But yeah.
Google Scholar today. But that leads us back on to cholesteatomas, because the same thing has happened there, that they've been able to look at quite a few skulls, because of course the cholesteatomas tend to cause bone loss, don't they? And so rather than having these bony growths with cholesteatomas, you've got bone loss. The soft tissue has gone away. The deposits that cause the cholesteatoma has eroded and just dissipated, but these eroded lesions within the skull are still there. So they've looked to see that the health of people's hearing up to sort of 6,000-7,000 years ago.
I mean, you get a very characteristic bone loss, a very characteristic pattern of bone erosion. That's an interesting one, because I'm not convinced there is a strong socioeconomic bias to cholesteatoma. It's said that it's got some socioeconomic preponderancy, but I'm not convinced. I think it's fairly flat from that point of view. But you certainly can look at health and you can certainly work out what people died from, because it does kill you.
Yeah, it predisposes to neural infections, doesn't it? Brain infections.
Yeah, I mean, if you've got a cholesteatoma, you've got about a 2% annual chance of intracranial infection. So brain abscess, meningitis, stuff like that, which is why we tend to operate on it.
So if we sort of rewind for a minute for those viewers who are just about to switch off thinking they're talking long words, we don't know what they are. A cholesteatoma is, well, oma means growth, but it's not a tumour. So do you want to tell us what these growths are?
It sounds like a growth of cholesterol, and it's exactly not that. It's got nothing to do with cholesterol, and it's not a growth. Basically, the ear canal skin is naturally migratory. The skin and the drum and the ear canal are covered in squamous epithelium, which has got to shed the top layer like any other squamous epithelium. And because the ear canal is a tube, it would very quickly just fill up with dead skin. So there's a clever migratory pattern from the middle of the eardrum out onto the ear canal and out to the outside, whereby the ear cleans itself, dead skin comes out the outside, and that's how we make earwax. And you can actually see that if you put a little dot of ink on someone's eardrum and watch it over a few weeks, you see that dot of ink move outwards and move out on the eardrum and out along the ear canal.
We should just say, don't do that at home, guys.
Yeah.
If you do, use a very soft felt tip. Yeah, I wouldn't do it with a big biro. A very soft felt tip might be all right.
Soft felt tip.
Yeah.
Not one of those 0.3 mil Pentels, because.
No, and definitely not a propelling pencil.
Right. So sorry, yes, do carry on.
Sure.
Which is a really, really clever mechanism if it's going outwards. But if you get a retracted eardrum, or sometimes if you get certain perforations, it can start to go inwards, and then it takes on some really, really, really nasty characteristics, and it can start to eat away at bone. and set up infection, and you get all sorts of granulations. It activates osteoclasts, so all the bone disappears. And it's generally bad because, as we mentioned earlier, there's quite a lot of important clot work in that area. There's the facial nerve, there's the inner ear, there's your brain, and you don't really want to eating away at that. So,
how do patients present with that then, Nick?
Normally painless discharge, so recurrent infections. So
right.
they've had a runny ear on and off for a year or two, or sometimes 15 years. So it's sometimes just hearing loss, but normally it's just recurrent painless discharge in the ear. Right. And animals do get cholesteatomas, actually.
I've treated a few.
Yeah.
You say they're painless, and they're painless until you try and remove the plug.
Yes.
Is that right? And then they become very, very painful.
Not when I do it.
So everyone should go and see you. But some of them are picked up, I think, routine appointments, aren't they? For
yeah, I mean they are incidental findings quite commonly, and I think one that sticks in the mind is I remember a 5-year-old girl who came in with a bead stuck in her ear, and I took the bead out of her ear and found a cholesteatoma behind it.
Gosh.
And so they are sometimes incidental. You could argue that she'd stuck the bead in the ear because the ear was irritating it because she had a cholesteatoma there, which is possible. But you do pick them up incidentally. And when you pick them up incidentally in someone who's older or not so fit for an anaesthetic, you've then got that difficult decision of, do you operate on something that's a potential health threat but isn't causing them any symptoms, in someone for whom an anaesthetic can be an issue. So yeah, that's often a difficult discussion.
And when you remove them, do you remove them via the ear canal, or do you have to?
No, I do them all with an incision behind the ear. Mm-hmm. You can do all sorts of clever things, and increasingly now for small ones we're using endoscopic techniques. So with a combination of the endoscope and the laser, you can get to all sorts of things that you didn't used to be able to get to. And the laser's really good for it. You can just take little bits of cholesteatoma off the ossicles without taking the ossicles out, which is a big step forward. We used to have to do big operations, remove all the bone, remove the ossicles, and we're getting a bit more subtle with it now.
We're still at the not subtle stage. I've got a picture here of one. People who are of squeamish nature may want to turn away.
Brenda, you shouldn't be on this far anyway.
But here's the ear canal from a dog with a cholesteatoma, and it was huge. It was actually emanating from the middle ear, and had actually taken over the whole of the horizontal canal. So dogs have this sort of L-shaped horizontal canal and vertical canal.
For listeners to the show rather than viewers, Julian was holding up a photograph, a cutaway of an actual operation that he'd done on a dog's ear. And the way to get hold of that, of course, is to tune in online and watch the video version of this. And you'll be able to see in quite graphic detail the retractors and the blood and the drapes and all of the good surgery he's done. Julian, how did that one end up?
It ended up like this. So there we go.
Oh,
there's
very nice.
And there's the line of sutures, and they actually do very well. It's a big op. It's very painful for them. They've been kept in for a few days, but it's totally ear canal ablation, usually with a lateral bular osteotomy combined. So we're taking out the ossicle, we're taking out usually a lot of debris from the tympanic bulla. But we lack the finesse at the moment to be able to remove the steatomas endoscopically. It's coming. We'll get there.
Well, you've got an endoscope, haven't you? You've got an endoscope?
I have, yeah. It's 11 millimeters, a bit big.
Get a smaller one.
What size is yours, Nick?
Well, he goes down to 8 millimeters.
This is not something I say very often, Julian, but I'm pleased to say it's smaller than yours. Good question.
We might know if Nick tells us.
We can have a look. What do you think?
It's a surgeon disguised as a rubber duck. That's brilliant.
I suspect it probably is.
Fantastic. So you're wearing surgical scrubs and a mask. Excellent. I like that.
I think our viewers will like that as well.
They would.
I hope your rubber duck isn't special to you, Nick.
If Palm could come to a rubber duck that people want, like that.
It was given to me by a friend. When I started doing paediatric ENT, I used to keep a rubber duck in my briefcase for distraction.
Yep.
And it was amazingly good, actually. And I always used to say never underestimate the power of the duck. And that was a present from a friend of mine. Yes.
How do you turn a duck into a pop star?
What?
How do you turn a duck into a pop star? You stick him in the microwave till he's Bill Withers.
I've not had enough gin for that one.
Sorry, do
get another one quick.
So let's see. So we've done these little exostases from surface here. We've done stapedectomies. We've done cholesteatomas. I know one of your favourite operations is mastoidectomies. See, we don't have mastoids in dogs and cats, so I've never done one. But you've found a great deal of success performing radical mastoidectomies, haven't you?
Yeah. I mean that's the operation. One of the operations I did for cholesteatoma. So in animals, obviously it's just really something down the ear canal, but in humans, because we've got this mastoid, this big honeycomb of bone behind the ear, that's where the cholesteatoma tends to go and where it tends to hide. And so you spend a long time trying to get it out of the mastoid with doing as little damage as you can. And I've moved more away from modified radical mastoids into all sorts of other things now, and because one of the downsides of radical mastoidectomy is that you've not got a normal ear. It accumulates wax. You've got to keep water out of it, and you're kind of giving someone a chronic health issue. They need to come and have their ears cleaned out every few months. It's something they've got to worry about, which is okay. It's not the end of the world, but it's certainly in kids. I don't like doing it, and in anyone who's young, active, wants to swim or whatever. I've moved away from modified radical mastoids, and I do other stuff now. And there's all sorts of ways of doing what's called a combined approach procedure, where you tunnel through the mastoid and through the ear canal. Often use the endoscopes with that. Often use the laser with that. And you actually try and give someone as normal an ear canal as you can. Sometimes it takes more than one operation. Often you do as a planned 2-stage procedure, because the cholesteatoma's got a nasty habit of coming back, and you can't always see if it's come back. And scans aren't quite there yet in terms of picking that up. Some of the MRI sequences now are getting better at it, but they're still not quite there. So yeah, I mean, I've done about 600 or 700 mastoids now, and I could probably say that no two have been actually the same. That you just kind of deal with what you've got, and I wouldn't say make it up as you go along, but you certainly adapt as you operate.
You're making my ears very itchy.
That's because
I'm glad you said that. I've been dying to scratch mine.
Absolutely. So
one of the biggest problems we have with dogs and cats' ears is that of recurrent infection, and obviously with antibiotic overusage, we're constantly being advised to reduce our antibiotic usage, and we do that by performing culture and sensitivity tests before we give the antibiotics, but also we try and use other things. We use flushes, we use washes, we use things like Bureau's solution, and acetic acid, and even honey these days. Do you have a problem with recurrent ear infections in people that aren't caused by steatomas and things?
Oh yeah, for sure. You get a lot of recurrent otitis externa, which is basically just a skin infection of the ear canal. Similarly, we try and avoid using antibiotics if we can. Acetic acid we use. And there's some stuff called ear calm you can buy over the counter, which is basically an acetic acid spray, because obviously you change the pH and the bugs don't like that. Not tried honey, I have to say. It's not one I've tried. I'd imagine it'd be quite sticky in an ear. But we do see quite a lot of recurrent ear infections. In humans, the easy way of doing it is you just tell people to get their ears dry. And if you're a swimmer, you wear earplugs. And 9 times out of 10, that stops it.
Mm-hmm.
Obviously, with dogs, it's slightly harder to get earplugs in them.
A little bit. In some ways, the earplug problem would exacerbate. Sorry, the earplugs would exacerbate the problem because of this right angle turn they have, and the fact that dogs with inside-out ears, floppy ears, have a natural barrier which creates a sort of incubator within their ears. But it's usually multifactorial. So we see dogs with allergic skin disease having the worst ear problems. And more often than not, just changing the food to a hypoallergenic food will sort them out. Making sure that, as you say, that if they're swimmers, we reduce their swimming. But
So would you suggest hypoallergenic kibble for my patients?
I would do, yeah. Try them on Hill ZD. Other foods are available. Or salmon and potato. That's quite a good one.
If you actually hide it in the two sides of a baguette, then
now you're talking.
Feedback sandwich.
Feedback sandwich. Well, or feedback baguette.
Yes,
as it's now going to become known. Yeah, absolutely. Well, that's
one of the treatments for chronic otitis in dogs used to be to do something called a lateral wall resection. Have you come across that? It used to be a ZEP.
Sorry, I was on baguettes again. Sorry, you were saying?
So we used to treat dogs surgically to help with chronic ear infections by doing this thing called a lateral wall resection, where we'd make an incision either side of the ear canal and fold the canal down and create a sort of draining platform. And they'd invariably not work. It was an absolutely crap procedure. It's called Zepp's procedure, and he should have been burnt at the stake for even suggesting it. I think there are still a few vets that qualified before 1976 that are still doing it. But by and large, it's not a good procedure. And there must be a lot of procedures, I guess, in the human field as well that used to be de rigueur 20 years ago or so.
Yes, Mr. Zepp. What can I do for you? You're watching the internet live. Right. No. If you hadn't phoned us, then you'd have heard that Julian was extolling the virtues of Mr. Zepp's procedure, your procedure. Yeah, no. Watch it again on replay. It's going to be on in a few hours' time. Yeah. No problem at all. Thank you for your call, Mr. Zepp. Yep, there you go. Bye. Yeah. Julian, that was Mr. Zepp on the phone.
Has he gone?
Yeah, he's gone now.
He's gone, yeah. Sorry, Zeppo. Any odd thing you used to do when you first qualified that a guy out of favour?
Oh, lots of stuff. Lots of stuff. Some because better stuff's come along. Some because it just didn't work. Excuse me. We used to do all sorts of horrible things to people. We used to cauterize their noses with hot wire, and if you're having recurrent nosebleeds, you would literally get a what looked quite a lot like a soldering iron, and essentially you'd use a bit of local anaesthetic. Have you had this done?
Yeah, I had that done for not handing my Latin homework in once.
I bet they didn't use the anaesthetic for you, did they? No. It worked quite well. Right. Patients don't like having the smell of their own burning flesh in their nose, and that was one of the drawbacks. And also you'd singe the hair. It was just bad, so we stopped doing that.
Good. I got Nick a bottle of this. Now this was it was a special birthday.
This is a gift, was it? This is a special gift.
Knowing how Nick and I share a love of whiskey, so knowing how he likes whiskey, I went into the whiskey shop and they said, "You need to try this. It's an English whiskey." And I said, "Well, not convinced." And they said, "No, it's very rare." So I bought a bottle. It was stupidly overpriced, and I thought I'll give it to Nick and we'll try it together. Jesus, it was horrible, wasn't it? It was. I
Well,
hope
I'm
you
not.
feel
I'm not one to be ungrateful about a present. It was awful.
it was. It was undrinkable. It was foul. I would prefer to drink creosote and have done. It was absolutely awful.
I have actually since used it to treat the fence.
Well, don't put the egg anywhere near it, will you?
No.
Which is odd though, isn't it? Because the Welsh single malt is
Well, Penderyn, that's quite decent. That's decent.
That's nice.
Mm.
What do the Scots think of this?
They don't mind. They're making enough money on theirs. They're okay. I'm actually always in awe, Nick, about the surgery that you do. It's absolutely fascinating. Really fascinating. So we tend to do sort of butchery, I think, sadly, rather than surgery. That total ear canal ablation that I showed you. There's a bit of finesse. You've got to mind the supraauricular artery and the facial nerve, and so there's some fine dissection, but it's basically whacking out the whole ear. And I can't help feeling every time I do it, there's got to be a better way. Unfortunately, I do fewer and fewer because actually these days we can medically manage most of them.
Mm.
But it's a horrific op. Most times it works, and if you dose them up with enough analgesia, they're fine. And 2 to 3 days later, they're perfect and never look back. About 1 in 20, I suppose, get a recurrence of the infection, and they then develop these deep-seated abscesses that are a real nightmare to get rid of, because you then got to go in there and dissect everything out and try and find the facial nerve again and put a drain in. We usually use active suction drains these days. And I'm lucky. All the ones I've gone in on again have got better. But there are some horrific stories of dogs that have had to be put to sleep because you can't control the infections, their recurrence, and they get facial nerve paralysis.
How often would you prang a facial nerve do something like that?
You prang with cats about 1 in 2, but temporarily.
Yeah.
So all cats will develop horners for 3 or 4 days afterwards, and some cats will have mild facial nerve paralysis for 3 or 4 weeks afterwards. About 1 in 5 dogs will have mild facial nerve paralysis, and about 1 in 10 dogs will have complete facial nerve paralysis, because they're the ones that develop real calcifications around the facial nerve. And you try your very best to dissect them away, but there are some that you just
Can you get EMG monitoring though for dogs? Because we use passive EMG monitoring the whole time on the facial nerve. So
the answer is yes. I'm sure you could, but it's not done purely through cost reasons.
Yeah.
Well, I say purely through cost reasons. No one has the setup to do it.
But you've also got to have them not paralysed. I mean, Mike, you anaesthetist, do you paralyse them when you ventilate them, or do you have them not paralysed?
No, not paralysed.
Not paralysed.
That's one of the things that I find. How do I describe this? Slightly frustrating from a physiological point of view. In human medicine, if somebody's going to be hooked onto a ventilator, they are paralysed. In veterinary medicine, we hook them onto a ventilator because they're anaesthetised. And it's from a finesse point of view, again, when we're talking about finesse in surgery and in anaesthesia, there's a massive difference. Although, interestingly, I was in an orthopaedic list fairly recently, just before lockdown, and the patient was being actively supported. So the level of anaesthesia was such that the patient was having a total hip replacement under local anaesthetic. So the patient was sedated, not heavily enough that we couldn't communicate with them. They weren't intubated, but there was a pressure sensor on their mask, such that if the ventilator felt they required extra assistance to breathe or to take a deep breath, then it delivered supplementary support. Now, this is way beyond anything that's going on in routine veterinary medicine.
Oh, absolutely. I mean,
That's quite clever.
It was incredible. I mean, we were literally talking to it was quite a surreal situation, because we were watching the monitors and the ventilator delivering or helping to deliver a full breath to the patient that we were talking to, whilst the head of the femur was hanging off the side of the table as the surgeon was chopping off the end of the head and neck of the femur. It was a very surreal situation.
I think the trickiest anaesthetic I've seen given is when you're doing stapes or middle-ear surgery under local, and we used to do it quite a lot in Australia, and then you've got to basically, because injecting locally into the ear is spectacularly painful.
Yeah.
So you give them basically not quite a GA, but without intubation to stick the local in.
Yeah.
And so obviously going to try and keep their airway, but keep them breathing spontaneously, and then wake them up during the operation.
Yeah.
Without them going, what the hell is going on?
Yeah.
So that by the time you then put the prosthesis in,
yeah,
you can make sure it's in the right place and ask them if they can hear.
Yeah.
And that's quite a clever bit of anaesthesia.
I think it's superb. I've seen similar stuff in eye surgery as well. Again, where you're communicating with the patient, and you need to be able to, but they're all locked out and you've got half the eye out. Yeah, no, that's incredible stuff. I'd love the idea of that sort of stuff.
Well, I had my lenses replaced a couple of years ago.
Right, I didn't know that.
And obviously it's done under local, and so the surgeon's talking to me throughout, and I could tell what was going on. Just I couldn't see much. Well, all I could see was a bit of light.
Yeah.
But I could hear what was going on. I said, "So you got the phaco going now, have you?" He said, "That's right. Yeah. Would you set the pressure out?" I said, minus 20 bar. Oh, that's pretty good, isn't it? So okay. He said, "Are you not at all squeamish about this?" And I said, "I'd be squeamish if I suddenly heard you say, oh fuck!" But until that point, no, I'm not squeamish. Nick, you've been suffering, haven't you? Because you're wearing a mask and a visor for your stuff.
We've had all sorts of stuff. I haven't done a mask yet since COVID, but we've got to wear FP3 masks for that. So those are the proper sealed ones because of all the aerosol and stuff.
Yeah.
And those are hard work. I mean, they're not unlike having a sort of scuba diving rig in for the whole time. There's that level of resistance. When we were doing the COVID sort of ITU support, doing the trackers and stuff, we were in the full hoods, full spacesuits, and that was quite interesting. Because you're trying to coordinate a theatre team where you're in a space hood, your assistant's in a space hood, the anaesthetist in a space hood. And trying to actually coordinate that. It's we had to learn all sorts of new ways of working quite quickly. It was interesting.
It's interesting and not pleasant. I worked for a brief time at Purbright doing rinderpest and foot and mouth anthrax, etc. And we were in there's a Cat 4 lab. And so we were wearing those sealed masks and NRBC suits.
Nice.
And the lab was set at a constant, I think, 15 degrees centigrade, because any lower than that, and the air would humidify too quickly, and the mask would bung up. Any hotter than that, and you would just work for 20 minutes and collapse. So it's 15, and it was pretty strict. If it went up to 18, then alarms would ring, and you'd have to pop out for a while till the aircon cut in again. But that was unpleasant, and all your movements actually were controlled. So the first few days, I found it awful, really oppressive, and thought, Jesus, I'm never going to enjoy working here. After that, actually, you get used to it, and you're there, and the effort you take to breathe in, breathe out becomes unnoticeable. But when you go out again afterwards, so you go out and you have a shower on the way through, and then you change, and you suddenly think, "Oh gosh, I'm taking huge breaths."
Tell us about your experience with COVID. With COVID, Nick.
Yeah, it was yeah, about as much fun as I've not had ever, really.
Right.
I came home one night, felt a bit fluey, just a bit achy. Said, I think I'm going to go and sleep in the spare room.
Right.
And I was supposed to be going in the next day for a meeting, and I phoned up and said, look, I really don't think I should be coming in. And they went, well, what's your temperature? I said, oh, it's only 37.2, but I don't feel great. And they went, you should probably come in. So I came in, sat in the corner, didn't go anywhere near anyone. Got home, temperature was 38.2, and then spent the next 10 days in the spare room. And it was basically what happened was about the first 3 days, I just felt rubbish, fluey, really knackered, and then felt better. My temperature came down, and I thought, oh, this is great, this is really good. And then the night of day 3 started to feel rubbish again, and then just got worse and worse and worse, and then got the dry cough. And then I think day 7 was the worst, when the temperature didn't come down at all day, but about 38, even though I was going through a load of paracetamol and stuff. And just felt awful. And that was the time when you were, it was early in COVID, and the received wisdom at that stage was that at day 7, you either got better or went to hospital and went to ITU. And so when I was getting at my worst. So that was quite troubling. And then about day 8, temperature came down a bit, still spiking up to about 39, and then eventually day 9, day 10, it came down. I was quite lucky that I didn't get too much in the way of respiratory stuff. Did lose my sense of smell, which was a real worry when it came to the wine cellar.
How long did it take to come back?
I did a little randomized control trial on myself, and stuck some nasal steroid up one side of my nose and not the other. And it made absolutely no difference at all. And they both came back after about 3 weeks.
Right. So now I think it's the feeder cells for the olfactory neurons, don't they?
I mean, a lot of viruses are toxic to the olfactory neurons. Influenza virus is known to be toxic to the olfactory neurons. So that's probably the commonest cause of anosmia.
Particularly the NWS version.
But it seems
not safe for work version, Julian.
Sorry?
The not safe for work version.
No, the NWS, not NSW.
Oh, right.
NWS. It's a neurotropic form of influenza A.
But I mean, the thing that was striking when I got better was just how knackered I was. I mean, our garden is not long. It's not a big garden, and I thought, when I felt better, I'll go for a little walk. And I got about a third of the way up the garden. I had to stop and sit down for 10 minutes and then get back to the house.
Bloody hell.
That's not good.
And then after about a week, had enough energy to go out for a bit of a dog walk, and got up the end of the road and turned left and got up a little slope and started to get some chest pain. So which was interesting. And I did all the research and went, oh, there's nothing there. Yeah, you can get cardiomyopathies and you can get this and you can get that, but there's nothing about any sort of coronary symptoms. So I thought, I'm just putting this on. So I went out the next day and went a bit further and got a bit more chest pain. I went, maybe there's something in this. So I then went on to turbo and just stuck the heart rate monitor on and just did a ramp test. Went up sort of by 5 BPM each 5 minutes. Got up to about 130 and didn't die. So I thought I'm probably all right. I think I probably had a bit of pericarditis because I got a bit of chest pain on and off afterwards. But yeah, I got better, and then it took me about another 3 weeks to get back to work. And then just thought I'd better sort of rehab myself. So actually now I'm fittest I've been for years. But that's just because I sort of rehabbed myself and didn't stop. So it was not fun.
So how long would you say that it's impacted you then? I mean,
I was ill for 10 days, off work for another 2.5 weeks, and not right for about a month after that. So probably a couple of months.
So a couple of months. So you're into your bike riding, your long distance cycle rides, your taps. So 60, 70, 100 mile ride, you just just go and do it, wouldn't you?
Yeah.
Okay, so a fit, healthy individual, and it's taken you out of the game for a couple of months.
Yeah.
It's, incredibly fit. It's in the upper 5th centile. This is. I think what it's saying is actually don't piss around, wear a mask, isn't it?
Yeah, absolutely. I think we probably should, Julian. Looking at the time, I'm wondering whether we should actually close out our CPD session of ENT surgery, both human and veterinary, this evening. Have you got a certificate for us?
I have. I've got a certificate, yeah.
Okay.
Yeah. So here we go. Here's a certificate. And it says certificate, and there's a lot of small writing. Certificate of seriously intensive knowledge acquisition. This certifies that our faithful viewer watched at least some of this week's broadcast. It says, "You rock, Dud," because it didn't recognise dude on autocorrect. So
I thought that was an homage to Dudley Moore.
Well, actually, Dudley Moore, he rocked, didn't he? He rocked. And Mike and I
Peter Cook as well.
Homages the other day, weren't we? Anyway, there we go. So there's no, there's another problem you tend to see in general practice, which is squamous cell carcinoma of the ear, treated by pinectomy. Squamous cell carcinoma of the nose, treated by nosectomy. And unfortunately, we also see that. And I know that you see a lot of aggressive trauma cases. We've spoken about those at other times, and maybe if we have you on again, you'll tell us some of those fun stories, like keys in ear canals and things like that.
Yes, that was an interesting one. Yes.
Yeah.
Well, fair enough. I mean, for some viewers, I think we should explain that ectomy means removal of. So if you didn't actually get the nose ectomy,
or a northern cry of "pass it to me," ectomy.
On my head.
Heck.
No, I don't do football, Julian. So listen, let's close out our CPD, I think, because you have to do CPD as well, don't you, Nick? Do you not have to show that you have?
We have to do quite a lot. Yeah. Some of it we have to go to really horrible places in the world to do as well.
Yeah, sponsored by drug companies very often, but
unfortunately, they've kind of stopped that. But you have to pay for yourself. But yeah, they do often put conferences on in some dreadful locations.
Yeah, so this is like up at 7, get the first lift up, ski till 11, 3 hours of lectures, and then back out on the slopes again to get the last lift down, where you might have a meeting in the bar afterwards.
I couldn't possibly come in.
Okay. Or
we go to Birmingham for most of our CPD, although from next year we're going to Manchester.
Yeah.
Oh, that's nice.
How much CPD do you have to do then, Nick?
50 hours a year.
Right. Okay.
So yeah, which actually, when most meetings are sort of give you 3 or 4 hours, is quite a lot.
But the vets have got it easy then.
Oh, obviously. Well, we work ridiculously hard as surgeons, so yeah. I mean, yeah. Anyone else is just,
Yeah, but
don't know they're born really.
Well, there you go. But I bet you don't have to reflect on your CPD, do you?
Oh God, I have to. Not only reflect on the CPD, I have to then demonstrate how it has improved my practice and reflect on how it's improved my practice.
Oh, really? We just have to reflect.
We just reflect.
Should we show you? We'll do some now. We'll do some reflection.
Let's reflect on the CPD that we've had tonight, and thank you very much indeed, gentlemen, for such intense CPD. But a moment of reflection, please.
And reflect. Yeah,
that's freaking awesome.
Brilliant.
Yeah, but what I mean, if we go by Nick's rules, we're going to have to reflect on how it's actually improved our practice. So I suppose if I put the cap on the lid to clean it out,
that's it. I think it's
I didn't see that. I didn't see that.
No, it's all right. No, Nick, I have been paying attention. I have capped the end, so it's not just the pointy. It's not just pointy bit. I've cushioned.
Now, I was once told that you shouldn't put anything smaller than your elbow down your ear.
That is actually very, very good advice.
Because
How am I
people
going to get
do
my
a lot
elbow
of-
down my ear?
How many injuries do you see due to cotton buds in ears?
Oh, loads. My general advice with cotton buds is actually to get all your cotton buds and build a small pile of them in the garden and burn them.
All?
They're good. They're good for ferrets, though.
Are they?
Yeah.
In what sense?
How?
Well, now I'm glad you asked. If you
Did we have an option?
No. If you keep a female ferret on her own, then unless she's vaginally stimulated on occasions, she will develop osteoporosis and die. Now, the best thing to do is to keep a male ferret, or ideally a vasectomized male ferret, and they can do the job. We had an American lecturer at college telling us about this, and he said, what you can do if you've not got a male is you can stimulate her with a Q-tip. And I was thinking, you've got to be good. I didn't know that Q-tips were cotton buds in America.
Julian is simulating the motion of a snooker player about to pot a ball on the green beige of a snooker table. No, Q-tips are earbuds. In fact, it's quite interesting because
No, they're not earbuds. No, they're cotton buds. They're not
cotton
earbuds.
buds. Well, okay, cotton buds.
Never ever put a cotton bud down your ear.
Okay.
Because actually it compresses the wax, doesn't it? Solidifies the wax and can damage the eardrum.
Right, it's very much like if you're loading a cannon, and you know those big things you used to stick the gunpowder down a cannon.
Yeah, ramrods.
Brian bless it.
Yes, yeah, that's pretty much exactly what a cotton bud does in your ear.
So it would probably be better to pour honey into our ear and get our dogs to lick it.
Sorry about that. Yeah.
Yeah, but we could reciprocate. But no, we couldn't reciprocate.
You can't. No, the RSPCA are against that with good reason.
Sure?
So never take home message. Never stick anything down your ear.
No.
Please. Good.
Oh.
Unless it's someone else's elbow.
Unless it's someone else's elbow.
Which is fine.
I used to play rugby too. I don't know. So
well, that's fantastic.
It's absolutely super, Nick, having you on. Have you got a joke, Julian?
No.
With what we've
Yes, I have. Yes, I have actually. Yeah, I have got a joke. Yeah. I've got a joke about. I made it up earlier, so it might be absolutely awful. But it's about cycling, and it's about Nick as he was cycling along, doing one of his etaps, making a pretty good speed. What would be a good speed on the flat for you? Kilometers an hour? Because I know in the rules you've got to talk kilometers an hour, haven't you? You can't do any of this miles per hour stuff.
30, 35.
Okay, so you're doing about 35, and you look behind you, and there's this little kid on a bike, rapidly catching up. So you think, what the bloody hell's going on here? So you drop the gears down a bit. So you're up to 40 kilometers an hour. You turn back, this little kid catching up rapidly. You start to go uphill. You drop another couple of cogs, give it a handful, off you go, zoom, straight up. And you turn around, and he's almost at the back of your bike. He's saying, Mister. What's going on? So you slow down a bit. He says, Mister, you look like you're pretty good at cycling. Yeah, I've done a bit. He said, how'd you change gears on this? Yeah, it didn't work, did it?
Do we have sound effects for tumbleweed?
Yeah, we do. Every week there's another bit of tumbleweed that just goes fast.
Yeah. Yeah, no, I think it's called saying good night. And if anybody's enjoyed this evening, including
Up until then,
Julian's joke, then don't forget to click like and follow, and you'll be updated on all the new stuff that's happening on the show. And join us next week when we'll have another incredible guest. Nick Saunders, thank you very much indeed for joining us, and
It's been a delight.
such an
Thank you
insight
very much, Nick.
into your world of surgery. So, if I can bid you good evening, and may your dog go with you.
May your dog go with you.
Cheers.
Cheers.
Cheers, Nick.
And cut.
And that's it. There we go. That was fairly painless, wasn't it?
Is that all right?
Is that all right?
Brilliant. Thank you so much. Excellent.
Enjoy yourself.
That was great fun.
Yeah?
Yeah.
Good.
It's been lots of being down the pub talking crap.
Yeah. Well, that's
what it's supposed to be. And hopefully some people are going to watch this with that in mind. They're going to think, let's have a bit of banter. And
Brenda, this is not aimed at you.
and maybe
I did actually forget to mention that I have tonight. I've slightly reversed the dress code, because the current COVID dress code is smart up, casual underneath.
No, don't stand up, Nick. Don't stand up.
No, you can stand up.
Go on then. We'll trust you.
You know,
We'll trust you. I quite like you.
I mean, dinner jacket, trousers, and black shoes. I just thought, why not?
Brilliant.
Well, Nick, can I say thank you very much indeed?
It's been a pleasure, Mike.
Well, as long as you've enjoyed yourself, that's
It's been splendid. It's been great.
Good.
Hey, Nick, thank you so much. Thanks for coming, and thanks for coming on such short notice as well.
Yeah, really appreciate that too.
No problems.
All right. Thanks.
Right.
Have a good session.
Bye, guys.
All right. Good
Cheers.
night. Ta-ta.
Bye.
You're very love to kids. Bye.
Cheers. Bye.
He's gone.
What a decent guy. So, Mike, have you started your Christmas shopping yet?
Christmas shopping? Is it that time of year already?
No, it's always good to be organised. You don't want the last minute rush to find the perfect gift.
Gifts? That reminds me. Do you know what would make a wonderful Christmas gift?
Gin?
Well, yeah, but do you know what's better than gin?
More gin? No, go on.
Our great new Veterinary Ramblings merchandise.
Oh, yes, of course. Yeah. I'd love to find those in my Christmas stocking.
Well, let's see what Santa brings for you. One of our tapier badges, pin badges, perhaps?
Oh, I'd love that. Or, Mike, what about a framed photo? One of the copies of Phil Lamette's exotic animal photographs.
That would look lovely in my office, alongside George's beautiful greeting cards. Wow. I mean, I've got to say, thank you to all of the talented people that have provided us with these lovely gifts to give you all for supporting our Kickstarter.
If you'd like to get ahead of your Christmas shopping or buy some treats for yourself, treating, head on over to Kickstarter.com, not Crickstarter, but Kickstarter.com, and search for Veterinary Ramblings Podcast Fundraiser to see the different packages we have available.